welcome and thank you for attending the 5th National CFSD Clinical Pathways webinar. My name's Stuart Sutton. I am a GP in Renfrewshire and here as clinical lead for primary care, secondary care interface at CFSD. These webinars are designed to showcase pathways developed by CFSD in collaboration with clinical communities and to provide a forum for education, informal discussion and question and answers. And this particular webinar relates to the National qFIT pathway and its associated consensus document developed by CFSD in collaboration with clinical communities within NHS Scotland. With apologies, I am on audio only today due to a slight public transportation mishap, so apologies for that, although it will be to the benefit of colleagues, I'm sure. We're delighted to have Dr. Neil Cruikshank, consultant colorectal surgeon from NHS Fife and co-clinical lead for CFSD for gastroenterology, as well as Dr. Colin Noble, consultant gastroenterologist from Lothian. And as you can see on the slide we've got ahead of us, the webinar will be recorded and it'll be made available afterwards on the CFSD website. And there'll be an opportunity for questions and answers at the end of the session. And you're very welcome to put hands up, raise hands function at the end of the presentation if you'd like to do so and join in verbally. But you're very welcome also to put questions into the Q&A icon at the top of the page there, which is highlighted, and add any questions down the side, and we'll raise those questions with our colleagues at the end. With that, I will hand over, unless I've forgotten anything, I'll look to my colleagues, to Neil. Thank you very much.
Thank you very much. I've got control now. So we're going to talk about qFIT today, and I'll introduce the guideline and some of the evidence behind how we got to this point, and then Colin will take over. And I'll also discuss a little bit about iron deficiency anemia. So qFIT has been around for a while. It was first published by the team in Dundee using in primary care, and they published in 2016 and again in 2019. And they'd obviously been using this for a few years prior to that, those publications. So qFIT's been in use in Scotland for over 10 years in symptomatic patients. Craig's publication and a couple of others from Spain sparked interest in this. In about 2018, we had a big meeting in Edinburgh with the endoscopy leads and was agreed to set up the pilots, and that we'd use a qFIT test cutoff of 10 at that point, because that's what most of the studies had used. And we're going to predominantly use it in USC patients. And the reason for that was partly in Craig's data showing that the majority of cancers have quite a high qFIT test, and a lot of patients who have got no pathology in the bowel have low qFIT levels. And again, if you look, there's an interesting paper from Spain that looked at 1,000 patients through their clinics, and both with USC symptoms and both with USC symptoms and positive qFIT. We've had 17 cancers found, and in patients who were negative for the cancer guidelines at that time, they still found most of the cancers in those groups using qFIT, whereas in qFIT negative groups, they found relatively few cancers. And again, looking at the 5 data which we met again just prior to the pandemic, it was quite clear those patients with a very high qFIT level were most likely to find a cancer on colonoscopy, whereas the chances of finding colonoscopy of cancer in a colonoscopy on a qFIT negative patient under 10 was about 1 in 200 at the time. And we also found out that the levels between 10 and 20 were particularly low as well. But at that meeting, we decided to stick with the guidance of qFIT 10 and continue the pilot. However, the pandemic came on us, and Fife, Glasgow and Tayside pulled their data rather rapidly to try and risk stratify patients following that meeting to which patients we should use, we should go first for colonoscopy once the pandemic had finished. And it was quite clear that patients with high qFIT levels were the highest risk of cancer. Following that, we had the primary care guidelines coming out in 2003, where qFIT made an appearance. And again, that was patients with red flag symptoms, apart from iron deficiency anemia and a qFIT more than 10, should go on to have colonoscopy and be investigated. So why change the pathway a year later? Well, we had a lot more study, a lot more data. A lot of the English centres had published extensively in qFIT, and we thought it was time to review the whole group in a meeting face-to-face in Glasgow. It's happened at the Jubilee. And the things that we're looking at is whether we should change the threshold from 10 to 20. What should we do about iron deficiency anemia? And Edinburgh come up with some interesting data which they'd published on secondary testing and increasing the sensitivity of the test, which was thought was well worthy of further discussion. So my computer is playing up. And from that consensus meeting, the following points were really brought out, that the cutoff could be changed from 10 to 20 would be the new cutoff. But with safety netting of a repeat qFIT test at 6 weeks if patients remain symptomatic or there was ongoing clinical concern. For patients with non-red flag symptoms, which we'll go into in a minute, or no clear indication for a qFIT test, but a test that come back as greater than 80, we thought they should still be referred like a bowel cancer screening patient on the USC pathway for further investigation. And we found from the IDA data, which a couple of groups presented, both Edinburgh and Fife, but also anemia presentations from Tayside, that the USC criteria for iron deficiency anemia should also be applied at 20, but with a caveat that some patients may still need investigating with a slightly lower qFIT test of 10 to 19. And again, secondary testing was suggested. So what is an indication for a qFIT test? Well, any repeated rectal bleeding without an obvious anal cause or hemorrhoids should probably be referred for a qFIT test. Have a qFIT test done. Blood mixed in the stool. Patients with a change in bowel habit that's persistent and towards loose or more frequent stools should be tested. Patients with an iron deficiency anemia, and I'll go on to explain that a bit later, but mainly based on a ferritin level greater than 30. And those with persistent abdominal pain and weight loss over 5% should be referred and have a qFIT test done. We didn't think it was needed or should be delay the pathway for patients with erectile abdominal mass, and they should still be referred with as a USC patient. So where qFIT is not indicated, we probably should not be testing patients in primary care. Those patients with isolated abdominal pain or without any other concerning symptoms, which is mainly weight loss. Patients with a persistent thrombocytosis are quite a low risk of having colorectal cancer. We didn't think that was required testing. Patients with hemorrhage and anal warts shouldn't be tested. And again, likewise, patients with self-limiting symptoms such as diverticulitis or gastroenteritis probably shouldn't be tested. But most patients with mild diverticulitis are the same as population risk of getting a colorectal cancer. And it's only patients with perforated or complicated diverticulitis that have an increased risk. And usually those are patients that present to hospital and have a CT scan with a localized perforation. Family history, there's probably no requirement to qFIT test. There are separate guidelines that have come in the last couple of years about moderate and high-risk families. And it shouldn't really replace the screening program either. No, patients should be encouraged to go through the standard screening process. But we do accept that some patients will get a qFIT test outside of the guidance that is above 18 should be referred as if it was a positive screening test. There has been groups in England that have looked at low-risk symptoms, just going on to that briefly, but they're usually termed low risk because of criteria and age criteria that have been applied. And these are the differences between the NICE guidance of NG12 and DG30. And these are what they term as low-risk symptoms. And we know that patients without qFIT testing, the baseline risk in these populations is about 1.3%. But with qFIT testing, it was raised up to 7%. But we also found in these low-risk groups that the cutoff shouldn't be 10, it should be up to 30 if you want to approach a 3% cutoff. So in Scotland, in order so we don't clash or cross swords with the cancer guidelines, we've adopted no age thresholds. And so a qFIT test with these symptoms down to 40, we would still accept. But in order to maintain consistency and not have age-specific cutoffs for these lower symptoms, we've set the guideline at 80 until more evidence comes. So that's why we've not included age in our guidelines, but also tried to simplify it for primary care, that it's 20 with red flag symptoms and 80 with not currently for referral. Repeat testing has come in also from the data from Edinburgh, and it's recommended for patients with any qFIT test less than 20 with persistent symptoms. We suspect it should detect approximately 50% of the cancers that will be missed by the initial test. And this can raise sensitivities from 91 to 95%, or with 2 years of follow-up from 86% to 93%. So it's a good way of finding cancers that might otherwise be missed on an initial test with patients with persistent symptoms. And again, we'd recommend repeat qFIT testing patients with iron deficiency anemia or persistent symptoms. But whose responsibility is this? Now, we've been piloting this in Fife for over a year, and we accept that if a qFIT test is referred to hospital with a referral, whether it be pending or not, secondary care take responsibility for that testing. And if the test result is held within primary care, then clearly it's the GP who will retain responsibility for it. And in Fife, this is our vetting screen. So these are the options that we have when patients come in on a USC pathway or otherwise. And they can be vetted either the qFIT test is weighted, so the referral is, the clock stops and it's just suspended until it's available. And we have a team who fill in the numbers and tell us when those are available. The patients have a negative test, we can request a secondary test within our vetting screens. And again, if those tests are positive, they can be scheduled on for colonoscopy, or indeed, if we don't think they need to be seen in hospital, we can refer back to GP with a letter of advice as well. And we found that quite an effective way of managing the qFIT referrals in Edinburgh. But basically, each board is going to have to speak between primary care and secondary care to decide how they're going to manage these referrals. So looking at iron deficiency anemia, we published recently in Colorectal Disease a large study on this. These have been incorporated in the guidelines. The first thing is, what is iron deficiency anemia? And it's a ferritin less than 30 micrograms per litre. We haven't used T saturation, so I'll go into that in a minute. But the next best test, if you're still suspicious that they have an iron deficiency anemia, is to give somebody iron for 2 weeks. And if they are iron deficient, they'll absorb that iron, they'll make blood with it. And they should see an appropriate rise in their hemoglobin of 10 grams in 2 weeks. So if patients do come back with a borderline or high ferritin test, you can put those patients on iron. If they respond appropriately with iron added in, then they are iron deficient. Absolute iron deficiency is present in about 10% of women and 4 to 7% of men between 50 and 60. So it's an increasing prevalence in the population. But anemia of chronic disease is more common. 90% of women and 10% of men over 50 have a functional iron deficiency. And often the ferritin is normal or high here, but T-sats are low. And this is what the problem comes, is that many of the patients referred with iron deficiency on basis of T-sats don't actually have an iron deficiency. So we looked at this in Fife. We had 17,000 patients referred with blood tests. Of those, 14,000 we could determine whether they were iron deficient or not in various parameters. And we had full, complete sets of all blood results on patients, about 4,000 patients. Now, when we looked at qFIT and different types of anemia, iron deficiency or iron deficiency anemia, or no anemia or iron deficiency, we found that the predominant, with qFIT of over 400, over 50% of the cancers were detected in iron deficiency by a qFIT test, and significantly higher even when there's no anemia or iron deficiency present, about 1 in 6 patients. And again, even qFIT tests above 50, It's 10% and 17% of patients. So when we looked at the lower levels, we found, again, very low levels of cancers in the qFIT negative under 10 group. And even in patients between 10 and 19, the levels were quite low. We suspect many of these cancers may be detected on secondary testing as well. So this is where we decided that we were reasonably safe to draw the cutoff of 20, because relatively few cancers are below this, and we think the majority of them should be detected on secondary testing. So we didn't really find TSATs was very useful below a level of 80. The vast majority of patients with iron deficiency anemia will have a qFIT more than 80, which is not surprising. If you've had bleeding from a cancer, then you'll find it in the stool. And that's in fact only the additional pickup rate between 10 and 79 was only about 1.3%. And so we didn't think this was we should include T saturations in our algorithm. If it is done and the test is above 80, then clearly we would investigate, and we find the vast majority of cancers above this level. We looked at the gastric cancer rate in IDA, though qFIT has no influence because qFIT is broken down in the small bowel. So hemoglobin is broken down in the small bowel. And we found very low risk of gastric cancer in patients with iron deficiency anemia, about 1% in men and 1 in 500 in women over 50. And this is consistent with the data the BSG published last year, looking at the whole England endoscopy cohort from a NED database of over 400,000 patients. And they, again, found very low risk of gastric cancer in these patients. So these are the guidelines as they stand just now. There will be, I suspect, further evidence coming through the next few years, and the guidelines may be rewritten to take account of these things. They may look at the effect of repeat testing in primary care, age limits, low-risk symptoms. Do we include anemia in our algorithms? And is the asymptomatic cutoff at 60 fit for purpose, or should it be changed? So with that, I'll hand over to Colin to carry on the presentation, and we'll have questions at the end.
Thanks, Neil. So Neil's covered the sort of pathway in detail, so I was going to cover some more work that we've done locally and nationally about the double testing, because I know that's new. And then I was going to talk a little bit about other causes of lower GI symptoms, and then finally segue into sort of IBS management, which a lot of these patients eventually have and need managed for. So in terms of the second qFIT testing and the discordance rates amongst the testing, it runs at about 20%, and the ones that go positive, negative aren't of concern because you've got a first positive test. So it's that 10% where they go negative, positive. And what you can see from the red line in the table here is that the discordance rate stays relatively stable across the time frame of doing the double testing out to about 6 weeks. And in our study, where we had about 5,000 people, our average time was about 14 days, but you can see if you go out longer, it doesn't change. And one of the reasons, as Neil's alluded to, for the double testing is that you increase the sensitivity of the test. And what you can see here in terms of area under the curve is that the blue solid line is your single testing, and then the red dotted line is double testing, where people didn't complete the protocol, but 90% of people did. So it's quite similar to the green line, where that's the completed double qFIT protocol. And you can see that you can budge up that sensitivity, increase the area under the curve by doing double testing. And this schematic just shows what the Lothian data looked like from 5,000 people increased up to 10,000 people. So this is a secondary care setting where the GPs write in to ourselves as the gastroenterologists and the colorectal surgeons to say, can we do qFIT? The qFIT sanctioned by the qFIT office, sent out to the patient with another one about a week later. And you can see the data's all for 10, but pretty similar for 20, that about 24% of people are positive to start with, and they go direct to investigation. And that's true everywhere for qFIT. So I think Neil's caveats about who you should do that test on and who you shouldn't are important, because even if you use this test in 20-year-olds, you'll still get a positivity rate of around that value. So they go to investigation, and then you do a double test, and you pick off about another 7% that need investigated, and you enrich that group. So in our data, 10% of these people had cancer. So you investigate more, but you pick up the ones you missed the first time round. And then the other good thing about double testing is you have an added reassurance for a double negative, in that the risk of cancer down here in purple is about 1 in 1,000. And then with these group here, you could safety net them, you could give them advice, you could look for other causes for their symptoms, but you can say to them that it's highly likely that you have bowel cancer as a cause for your symptoms, and why don't we try doing something else? So that's really why that was adopted into the guidance. And if you look at, this is the completed double qFIT protocol, and the table on the top, the dotted line here, is the sensitivity, the number, percentage of missed cancers, okay, in terms of your total sensitivity. So you can see that if you investigated everybody that was referred in, you would need to investigate 30 people to miss no cancers. And that's not actually correct, because we know that even the gold standard test of colonoscopy probably misses between 5 and 10% of cancers if you look at people who go on to develop cancer less than 3 years after a colonoscopy. So that's not zero. So you can see a double qFIT negative at 10 performs exceptionally well compared to that, with a 97% sensitivity. When you go to 20, the number needed to investigate drops a little, but there is a slight trade-off in the terms of the missed lesions going up slightly. So that's the trade-off that happens at that kind of level in a secondary care cohort. This is more community-based from the data from the northwest of England. If you look at a large number, 28,000 patients who had FIT testing around this Preston area, you can see that, again, similar to our data, of those 28,000, about 2/3 of them, just over 2/3, were double FIT negative at a level of 10, and the risk of cancer in that group was really very low at 1 in 2,500. In the middle group were 1 positive, 1 negative, only 1 in 0.5%, and then higher in these with positive. And they redid their stats for 100, just to give you some degree of reassurance. So of that 28,000 people, now you've got 90% going down the double negative pathway of having 2 FITs less than 100. And of those, about 1 in 300 have cancer. So even at 100, you're picking up most of your cancers. And you can see in that group, if you're above 100, then you've got a very small enriched group with a cancer rate of 14%. So if it's not cancer, then what else can it be? Then I think you have to think about other causes. And this is the BSG IBS guidelines from 2021 from gut. And they're a wee bit blurry for me, so hopefully you can see them on your screen. But you have to think about doing baseline investigations. And as Neil says, ideally we would like to have the full blood count when the patient's referred in for their qFIT test, so we know what's happening. CRP is important, thinking about inflammatory bowel disease. Celiac serology, it's very prevalent, you don't want to miss it. And calprotectin, we'll come and talk about that a little bit in a minute, because I know some places in Scotland do have it and some places don't have it. So those are the tests you think about doing. Box 1 up here has people that you would refer in anyway, even if their FIT was negative. And those are people with microscopic colitis, so people with persistent watery diarrhea, so 7 or 8 times a day, up through the night, not constipation, classically middle-aged females with other immune-mediated diseases. So those are ones we want to know about as well, because they need a colonoscopy and they can't be reliably picked up by qFIT testing or calprotectin. So we like to know about those. And just to put a wee bit more meat on that, this is the Lothian calprotectin pathway. So you can see that we've split it up a little bit more, And on the far left-hand side, less than 50, just straight onto an IBS pathway. But what we said is to 150, repeat above 150. We'd like to know about these people. And if it's again less than 100 on the repeat one, IBS. If it's between 100 and 150, they refer. So the kind of threshold around about 100 is conservative but sensible in terms of thinking about referral in these patients where red flag symptoms have been excluded or they've been through the qFIT pathway and you think that colon cancer is unlikely as a diagnosis. We've just to go back to the BSG guidelines, they've put an age limit of 45 on this. The Scottish CFSD guidelines, there's no age limit on those. So I was going to spend the last 5-10 minutes or so talking about IBS because this is often the outcome where you have your double qFIT back, and the talk about the Rome criteria for IBS first of all. And you might think, well, why do I need to know about this? This is mainly for research. Well, it's helpful because if patients meet the Rome criteria, then they're very unlikely to have anything else wrong with them. So 3 months of recurrent abdominal pain once a day, symptoms onset for 6 months with pain related to defecation, change in bowel frequency, or change in stool consistency. And of the patients, if you follow those patients up, the ones that occasionally we miss pathology and tend to be in the diarrhea predominant IBS group. And we pick up cases of microscopic colitis that we chatted about before. We pick up occasional cases of inflammatory bowel disease and bile salt malabsorption, which is a disease that's symptomatically managed anyway. So helpful to kind of have a think about how you make a positive diagnosis in terms of managing their symptoms. And I think if you make a diagnosis, then we're down at the purple arrow here, then a clear explanation to the patient in the context of gut-brain axis disorders is important, and thinking about how to go on and treat the patients is really the plan, with a sort of follow-up plan of engagement in terms of where we go to symptomatically manage them. And this is a complicated algorithm from the same paper, but I've just put 4 arrows in here just to draw your eyes to the most important bits of this diagram, really the lifestyle advice, dietary advice, and what goes on top. And we'll chat a bit about this. And then I'm going to chat about kind of 3 drugs that you might be helpful in terms of interventions on the left-hand side for pain as a predominant symptom, in the middle for constipation as a predominant symptom, and on the right-hand side for diarrhea as a predominant symptom. So in terms of diet, I dish out this nice IBS diet sheet multiple times a clinic to patients, and it's really useful. It's very sensible, and it's got common sense advice. This is just the top half of it here about eating. You'll know that patients have hugely disorganized. A lot of patients have disorganized eating and eat very unhealthy diets. So regular taking time to eat, taking time to exercise. There's good exercise in terms of IBS symptoms, making time to relax. Food diaries are appropriate, and this also then goes on to have advice on bloating, constipation, diarrhea. And the British Dietetic sheet is very similar, and you can use either one. It depends what you prefer to use locally. In terms of interventions for dietary interventions for IBS, this is data from Alex Ford's group in Oxford, in Leeds rather, and he is really probably the world expert in terms of interventions in IBS. And just for these meta-analysis, anything towards the left favors intervention, towards the right favors the control group. And you can see really at the top of this table, starch and sucrose free, gluten free, FODMAP, all these diets that we're pretty familiar with in secondary and primary care, all the way down to the British Dietetic Association NICE IBS diet sheet showing evidence of benefit, and a diet right down to a high FODMAP diet, surprisingly, has no benefit in the sham diet. So thinking about diet is really appropriate, is really useful. FODMAP is helpful, but normally done with a dietetic support, so patients can go low FODMAP, normally for around 6 weeks, and then reintroduce in a structured reintroduction. So using resources that are available locally to do that is helpful. So diet works and should be explored as a first intervention. In terms of pain, this is a paper that was published in The Lancet 2 years ago now, but really added weight to using amitriptyline for global symptoms and pain in IBS. And a community-based, GP-based study from England with large numbers where patients were randomized to amitriptyline or placebo. And you can see this is the main outcome, that in terms of considerable or complete relief of IBS symptoms, somewhat or complete, you can see clear benefit for amitriptyline. So amitriptyline, and in this study, about 80% of patients had mixed IBS or diarrhea predominant. So there was a small cohort of constipation predominant patients in here as well. So 2 little tricks in this study that you might help you in terms of the management of these patients. The dose was escalated pretty quick, so started on 10 milligrams, but increasing to 20 or 30 milligrams in the evenings within 2 or 3 weeks, and around 40% of patients in the study escalated to 30 milligrams in the evenings. And side effects, patients were reassured that even if they felt a bit groggy in the morning, which is a common side effect of amitriptyline, or they got a dry mouth, just to persevere and things would settle down. And in the large number of patients they did. So amitriptyline looks, this is positive data compared to years of not having much data in terms of IBS. In terms of constipation, pegylated laxatives are really the first port of call, looking at spontaneous bowel motions, an increase of 2 per week. We can see double the rate in the PEG group compared to placebo in this study. It was done a little while ago, with the main side effect being headache, so sensible to try first in patients with constipation. Bonaglutide has been around for quite a long time and is licensed in Scotland for use if patients have failed 1 or 2 laxatives at full dose. And you can see here again that it's been of benefit against placebo in terms of increasing bowel motions per week and decreasing pain, and the major side effect being diarrhea. So the prescribed dose is 290 micrograms once a day. And in clinical practice, we tend to start it at 200 micrograms, 90 micrograms every other day, and then escalate if patients have a partial or no response. And if it doesn't work after a month, just stop it. So these drugs are good to have in your toolkit in terms of IBS management. And then the final one is going to talk about is ondansetron. So you're familiar with ondansetron as an antiemetic, but one of the side effects that's been known about for many years is that it is effective at slowing down bowels. And in terms of management beyond loperamide, where there's not a lot of evidence, but it's worthwhile trying anyway, this study, which was UK-based, included patients in Edinburgh, this really shows a benefit. And what you can see in the red line is the placebo, and the blue line is the ondansetron group, and this is number of days per week with loose stool. And this was a 12-week study where patients were started, and you can see a clear reduction in the treatment group with a fairly large placebo effect, actually, in the placebo group of a number of days of loose stool per week up until the end of the study, and then their symptoms reverting back to baseline. Normally, we would start on 4 milligrams to 8 milligrams a day of ondansetron. But the other interesting thing about this study was that they escalated people up to 8 milligrams 3 times a day. So some people did need a bit more. So I've been using ondansetron for quite a long time, but probably using slightly more if required is appropriate. So that's a useful drug to treat diarrhea, not useful for pain, bloating, or anything else, but pure diarrhea, predominant IBS. So finally, talking about psychological therapies. So a lot of patients will have already accessed these before they even come and see us, and we know that there's a lot of different advice things out here, but they do work, and you can see gut-directed hypnotherapy right at the top of the list. Relaxation, digital relaxation, so apps and things do work. They are useful to direct patients towards. This is another one of Alex Ford's meta-analysis showing clear benefit here, right down to routine care at the bottom. And in terms of local advice, we've got a patient-facing website that we do direct patients towards. So as Neil says, when patients have a double qFIT negative, what we like to do is to write to the patient and the GP looking at historic blood tests, but if they do seem to have IBS, to direct them towards a website. And I'm just going to play a video that was made by 2 of our psychiatrists about the management of IBS from a psychological point of view. So hopefully this will just play, I'll just play 10 or 15 seconds of it just to show you what.
Psychological aspects. What about starting recapping on above? So it's a gut disorder which affects the function of the community.
Great. So we can direct patients towards these. They can watch these at their leisure, and it just helps explain what's going on, and hopefully the self-help will be useful. So I am going to finish there, and hopefully I have summarized the value of double qFIT testing. We've talked about other potential diagnoses and gone a little bit into IBS management, which hopefully has been helpful. So if there's any questions, please ask myself and Neil and open the forum up. Actually, I've got one more slide, sorry. Neil, I just wanted to end with the pathway. Do you want to say anything about this, Neil? I think you're muted.
The pathway is available on the document attached to the QR codes at the end of this presentation, but also on the website for under endoscopy and Centre for Sustainable Delivery. But this is the basic pathway in that if you've got symptoms, you can do it. qFIT positive, you should be done a USC pathway. If you're under 20, you should be repeat tested and then becomes positive again onto USC pathway. And if you're double negative, then you don't need to be investigated. Patients with iron deficiency anemia ongoing symptoms may also be referred. And patients, what was not in this guideline is that if you're over 80, you should probably also be referred on the USC pathway as well. There's a separate section below listing. So we're open to questions.
So I think first thing I'd just like to thank Colin and Neil very much for those presentations. I think that was really helpful and presented in a way that was certainly digestible for a primary care perspective, so thank you. Just a reminder, if you have got questions, you can put them in the Q&A icon that will open a separate chat, which is really helpful to keep track of those, or you can pop your hand up and we'll bring you in if you'd like to ask a question that way. I think we had a question around amitriptyline, which was very pressing because it was then answered by yourself, Colin, almost immediately. So I think someone was ahead of the game there. That was really helpful. We've got another question here from Kaylee Gray. Is there any data around qFIT and polyps with precancerous potential? So I think that's a good one. I'll hand over to yourself.
Well, precancerous potential is a difficult one because a lot of adenomas will be declared as low-grade dysplasia with potential. But that potential can be less than 1 in 1,000, depending on the size of the polyp. So really, patients with polyps over than 2 centimeters are at greatest risk, probably. But they make up the vast minority of patients with polyps. When we looked at our qFIT data, we found that if you look at the bowel cancer screening data, the polyp frequency is approximately the same across the different qFIT criteria levels, really. And we looked at 5. We didn't find any dramatic rise in polyp detection with qFIT levels. I mean, you will find the polyps, but whether you should be screening patients for polyps, given that 60% of people who have a colonoscopy nowadays probably have a polyp. So unfortunately, with our increase in technology in the endoscopy units, you can find, if you look hard enough, you can probably find a polyp in virtually anybody over the age of 50. I mean, Colin would come in with that opinion as well. So I don't think we can use this. It's too non-specific in terms of, I mean, polyps are very common. So you know, if you investigate anybody with colonoscopy, you'll find polyps. But qFIT isn't very. It's like gastric cancer. It's not very good at discriminating who you should and shouldn't scope.
Yeah, and yeah, just to echo that the data on sensitivity of qFIT for polyps is not as good as that for cancer, because polyps are smaller and less likely to bleed, and particularly for polyps related to genetic conditions like Lynch syndrome and other things, they don't tend to bleed very much at all. So qFIT's not a good test for that.
Thanks, Neil and Colin. I think that's helpful. There's an element of realistic medicine, I think, in there as well, isn't it? In terms of not looking for and investigating everything that may kind of go on to cause challenges or not. We've got a couple of questions coming in now into the chat. So we've got one from Grant Rutledge. The Atlantis study references a self-titration document. Struggling to find this. Do you know where this could be found?
I don't, but I can have a look. Yeah.
Okay, that's really helpful. Thank you. Got another question. Given the majority of patients have a qFIT less than 20, over 70%, labs are facing significant increase in FIT requests. If double FIT guidelines are implemented, health boards will need to support labs in implementing this. This is a comment, I guess, more than a question from Judith Strack. I don't know if you've got any thoughts around that, Neil or Colin, around the capacity issues or the increased numbers, or?
No, I mean, we presented the data that Edinburgh produced on increasing the sensitivity. In general, I mean, the vast majority of the cost is clearly borne by colonoscopy, over £500 a test. But you are right, we have seen a steady increase in qFIT testing regardless in primary care since it was started. And we went from 4,000 tests a year to 16,000 tests a year. So it can increase at dramatic levels, and Colin's likewise seen in Edinburgh, even regarding it in secondary care, there's a 20%, at least a 20% increase year on year. So we are seeing more qFIT testing, and this is probably why we do need to be a bit cautious about which patients are getting qFIT tested, and it isn't a test for anybody with any colorectal symptom, just on the off chance I might find a test greater than 80. We have a bowel cancer screening service that is designed to do that very thing. But we are seeing a very large number of tests done in primary care. And we are seeing patients with marginal symptoms being referred in with qFIT tests greater than 80. It's difficult to know whether that's a good or a bad thing, but certainly boards may need to look at the level of support that is requested. There has never been formal qFIT funding top sliced from government for the qFIT pilots since it was envisaged. It was a service, certainly in our own board, that was borne by the cancer waiting times money. But you are right. If you can get 16,000 tests costs over £100,000. because it's
very much.
the tests are £1 each, but to analyse it's probably about close to £4 per patient. So it's not. It sounds a cheap test, but given the numbers, it becomes a financial burden to the labs. You describe right.
Not insignificant. I guess that's something for the boards to manage in terms of hopefully viewing that as a saving against the costs of additional colonoscopies. But we'll just a question there around how quickly do you arrange the second qFIT? I know the guidelines say within 6 weeks. Do you have any thoughts around whether that should be nearer to 6 weeks, or I guess that's a good question that GPs might want to know. Should we be saying come back at 6 weeks or 4 to 6 weeks? Or?
I think with iron deficiency anemia, it'd be reasonable to do it in a shorter time span, but the majority of patients may have self-limiting symptoms. They may have gastroenteritis, they may have a bit of food poisoning, and it's the same with calprotectins, that you may get a transient rise which subsequently settles. So if you think, it depends on the symptoms that patients are presenting with. If it's a single PR bleed, it might be, or a couple of PR bleeds, it may be worth seeing if that settles spontaneously. And likewise with diarrhea, it'd be reasonable to wait a little bit longer to ensure the symptoms aren't self-limiting, and then retest if the symptoms are persistent. Whereas other things which have a laboratory test beside it, if it's equivocal, you may decide to do an iron challenge and seeing whether you can confirm iron deficiency. And likewise, if you do have a definite iron deficiency and it's qFIT negative, you may decide to qFIT test a couple of weeks later, just to ensure that the qFIT test is negative and doesn't require investigation.
Thanks for that, Neil. We've got a few more questions coming in, so thank you. I think Colin's put the link in there to the IBS dietary information resource, and potentially, I don't know if is that linked within the document, the IBS guidelines, or maybe it's one we could send out as an attachment to those who've attended. If not, we've got another question around when is the guideline changing from 10 to 20 for qFIT cutoff, and I guess that will that be up to each of the boards to discuss at interface groups, ideally, in terms of time for him at the time they're going to implement that and notify primary care?
Yes, I think it's up to boards to decide when they go, but the guidance is live now. I suspect that 5 have been using this for a wee while because we knew what the guideline was going to be, and so we've been using it for nearly a year now and it's running quite smoothly.
Thanks, that's great, Neil. Okay, we've got another question around calprotectin assays being performed by different methods. This is I think this is one of our clinical chemistry colleagues, and asking, will the different assays affect cutoffs for the pathways?
Yeah, there are 2 different analyzers. There's an analyzer in Lothian which has a 50 cutoff, and the one we've just bought in Fife has a 60 cutoff. So I suspect we'll be looking at 200 to 240 being the different cutoffs depending on the analyzer you use. So again, you're going to have to devise a local pathway. I think the guideline came from York, and they have an analyzer that has a 50 unit cutoff. So you may have to adjust locally the calprotectin guideline to fit what you analyze. But again, if you discuss with your local biochemist, then they will be able to advise you what the appropriate guideline should be used in the board where it's being applied.
But I think we were going to use around 100, and 100 was what James Turvall used in the York pathway. And that's what's in the CFSD guidance.
Great, thanks, Colin. And I guess if the local analyzer deviates from that, then it's important just that to be flagged locally in terms of implementing.
Yeah,
that,
you need to be aware of what analyzer you're using.
Thank you. We've got another question from George Ramsey. Has the 4,000 to 16,000 increase in qFIT testing increased the colorectal cancer pickup volume by a significant amount? Feels like the system is overwhelmed currently by a number of positive tests, prolonging waits those symptoms. Neil and
No, it has increased the number of colonoscopies though.
Would it be fair to say
not all the patients who get tested in primary care are necessarily referred to hospital. So although primary care testing may have increased dramatically, there's a little bit of clinical decision making of is it appropriate to refer to hospital. We looked at the 800 positive patients who weren't referred to secondary care, and there's only 4 cancers spread over 2 years in those patients. So I think it's sometimes GPs are very good at deciding which patients should and shouldn't be referred. With patient symptoms settled, and largely you don't see that with colorectal cancers.
Thanks, Neil. Colin, you could comment.
Yeah. The only, I mean, I haven't seen it, but the Glasgow team think that the numbers of referrals, number of cases of cancer have gone up slightly in Glasgow, but certainly in Lothian, the numbers have stayed pretty steady.
Same
and I guess, correct me if I'm wrong, but I think part of the reason for changing the pathway, as we've described in terms of the cutoff and the repeat testing, is to avoid people who would have previously gone straight through for further testing that may not have needed it, and it would have been necessary to avoid those people going through, and that you're seeing the right people at the right time and prioritizing the right people. Is that kind of part of the aim of this pathway?
Yeah, 100%. So I mean, what we're trying to do, and what the nature of travel of colonoscopy is it's moving from a diagnostic to a therapeutic specialty. So what we're trying to do is get the right patients into endoscopy to do a high quality procedure on them to find their polyps and their cancer, and not investigate people who have low risk or who are frail, elderly, or who have comorbidities, etc. So it's really about trying to streamline that process, and maybe some parts of the country there'll be less direct to test referrals for colonoscopy for that reason. But the rationale is that's the kind of direction of travel, and qFIT's allowing us to enrich that population of patients that are coming to colonoscopy.
So by double qFIT testing, you will potentially investigate 31% of your patients. But by raising the threshold, you can, if you model it, by raising the threshold for 20, for scopes you save on raising the threshold, you can use to do your secondary testing, and you actually pick up more cancers that way. So you're using your resources more efficiently to pick up more patients with cancer.
Thanks, Colin. I think that's really helpful context. We've got a question in the Q&A box from a colleague in Grampian. PR bleeding with an existing anorectal cause like piles and a positive qFIT. We would probably end up doing a colonoscopy anyway. How important is the clause of anorectal cause versus positivity of qFIT?
So I say that again, they would investigate anorectal symptoms.
So I think the question is PR bleeding with an existing anorectal cause like piles and a positive qFIT, we would probably end up doing a colonoscopy anyway. So how important is the clause of anorectal cause versus positivity of qFIT? So I guess does it matter what the qFIT level is if you've got an anorectal cause?
I think if it's
likely,
many patients will have hemorrhoids for many years, and they'll know what their normal hemorrhoidal bleeding pattern is. And therefore, they tend to go to their GP if it's got worse or changed. It's concerning. If there's blood now in the toilet, there's blood mixed in the stool, they will present to general practice. And I think at that point, doing a qFIT test is important, because if you're qFIT negative, then the bleeding is most likely hemorrhoidal. And that was borne out by the NICE FIT study in England, in that the risk of somebody with rectal bleeding having a bowel cancer with a single test in that study was 1 in 200 with a qFIT test less than 10. And so there's a degree of safety netting there in saying that, well, if it's double negative with PR bleeding, it's probably hemorrhage and you don't need to have a colonoscopy. So I think there's good evidence that suggests it works in rectal bleeding as well. You can't just assume because you've got rectal bleeding, your qFIT test will be positive. The test works on degradation products of blood. Blood has to be broken down to reveal the hemoglobin. If it's whole blood, the test may not go positive, or most likely won't go positive, because it hasn't been broken down.
Yeah, I mean, we are still keen that these patients get a PR examination as well when they're referred up, because that can be one of the miss areas for qFIT
Yeah.
for the very reason that Neil said.
Thanks, Colin and Neil. I think that was a helpful question and clarification. So we are coming towards the end of our time. I think we've gone through all of the questions and answers there. So if any more, do pop them in the Q&A or the email address there if there's any other questions you want to send in that haven't been answered today. I think it just really remains to say thank you very much to Colin and Neil for presenting. Thank you to colleagues for attending and for the really useful questions. Just please a reminder to scan the QR code or go through the link there to provide some feedback to help us improve and continue with the sessions. And a reminder that our next webinar in the diary currently is the Scottish Referral Guidelines for Suspected Cancer, and the full review there is on the 23rd of September, 12 to 1. So I think that will be a really helpful and very much related topic. It links quite nicely with this. So thank you once again for attending, and we'll look forward to seeing you at the next event.